Hello, my name is Dr. Anthony Lembo. I'm a professor of medicine at Harvard Medical School, and I practice at the Beth Deaconess Medical Center in Boston, Massachusetts. My talk, which is part of the Nancy and Bill Norton Patient Education Series, is entitled Physician Introduction on Constipation. Chronic constipation carries a heavy burden on patients as well as society. It's estimated that 1 in 7 people suffer from chronic constipation. It affects the elderly more so than younger people, women more than men, and it's the 4th most common GI symptom prompting outpatient clinic visits, resulting in greater than 3 million outpatient clinic visits. And the estimated costs in 2013 alone ranged from $1,900 to $7,500 per year per patient. In 2011, national costs for ER visits exceeded $1.6 billion. So you can see from this information that constipation is very common. It affects a large group of the population and has a heavy toll on the medical system as far as costs. This slide shows you the worldwide prevalence of constipation. It's not only a problem in the United States, but it's a problem that affects people throughout the world, independent of their race or their diet that they consume. As you can see, both in the United States and Canada, there's a fairly high incidence of it, but it also affects people in China, Australia, and South America, and throughout Europe as well. Now, when we think of constipation, there are many symptoms that can be comprised of that. So when a patient comes to see me and says that they complain of constipation, I have to ask them, what do you mean by that? And here's a study that was done in Canada a few years ago, where they asked people in the public, not necessarily patients, if they reported constipation, and if they said yes, what type of symptoms they experience. And this shows you that data. And you can see the most common symptom associated with constipation was straining, or hard or lumpy stools, incomplete evacuation or emptying, stools cannot be passed, abdominal fullness, infrequent stools, interestingly enough, that is less than 3 bowel movements per week, which is outside the 95% confidence interval for what a normal person would have in the United States, represented only just under 40% of people who reported themselves to be constipated. So it's not the #1 symptom when someone refers to themselves as being constipated. Now, a few years ago, the Rome Committee came up with a definition for constipation. They called it functional constipation. Other people call it chronic idiopathic constipation. And because we know that there are a number of symptoms associated with it, the Rome criteria includes a total of 6 different symptoms. And for most of them, they need to be present for at least a quarter of the bowel movements. And those include the symptoms that we just saw: straining, hard lumpy stools, sensation of incomplete evacuation, anorectal obstruction, manual maneuvers, or the infrequent stools of less than 3 bowel movements per week. And loose stools should be rarely present without laxative use, and they shouldn't be able to meet the criteria for irritable bowel syndrome, because otherwise they'd fit into the IBS with constipation category. And in order to be chronic, patients have to fulfill these symptoms for at least 3 months, with an onset of at least 6 months prior to the diagnosis. Now, when you have experienced constipation and when it is chronic, there are a number of things that we should rule out before we consider it to be functional constipation or chronic idiopathic constipation. The slides lists out some of them. Now, most of the time it is functional or chronic idiopathic. The secondaries are less common, but these are some of the ones to consider. Now, the #1 cause, in my experience, is medications. We see a number of different medications that are associated with constipation. We all know that narcotics or opioids can slow down the gut and invariably cause constipation. Calcium channel blockers are also very common. Calcium supplements, anticholinergics, just to go down the list, there's a number of different medications. So anybody who's on a number of medications should really look at the package insert to make sure that that's not the trigger for it. And usually it's temporally related. Less likely there be mechanical obstruction, such as a cancer or something blocking it, particularly if it's chronic. Metabolic or endocrine disorders are rare. I've listed some of them here. Neurological disorders are very commonly associated with constipation, but again, these are pretty obvious when they're present. Psychiatric disorders, people who are depressed tend to be constipated, and constipation can improve when the depression improves. Cardiovascular and pregnancy are all things to consider. But let's focus in on functional constipation, because this is really the most common disorder. We think of 3 different subtypes of constipation, which are shown on the right: normal transit, slow transit, or defecatory disorder. And defecatory disorder can overlap with both normal transit and slow transit constipation. As you can see on the left-hand slide, there are a number of disorders that are associated with these subtypes. There's diminished colonic propulsion, or the way the colon contracts and moves, which is associated with slow transit constipation. And a defecatory disorder, there's inability to relax the anal sphincter and relax the pelvic floor muscles in association with bowel movements. And normal transit really overlaps the most with irritable bowel syndrome with constipation. This slide shows you some of the overlap that can exist. And we think of these 2 disorders, that is IBS with constipation and functional constipation, as really overlapping a continuum. So the more that the patient is in pain, experiencing pain frequently and regularly and associated with bowel movements, the more likely it is to be IBS with constipation. If someone has more severe constipation, the more likely it is to be functional constipation. So this slide just shows you the initial diagnosis that we do when we see someone with chronic constipation. We do a thorough medical history, physical exam, and importantly, we do a digital rectal examination. And this is really to look at the pelvic floor muscles, the way they relax when we ask someone to bear down like they're having a bowel movement. The pelvic floor should be able to relax several centimeters, and the puborectalis muscle, which is a muscle that makes the rectum go at an angle, should be able to relax as well. So that's a very helpful part of the examination. We look for alarm features, and those include weight loss, blood in the stools, or someone with the new onset of constipation over the age of 50 or 60 years, progressively worsening constipation, or family history of colorectal cancer would all be considered alarm features. And in those people, we would want to investigate further. We want to consider doing a colonoscopy, for example, to make sure that we didn't miss a cancer or a polyp or other causes for it, then treat appropriately. But if alarm features are absent, then we really want to look at lifestyle factors. So we want to look at the amount of fiber that someone's taking, the fluid intake, and physical activity, because these 3 things can really help people move their bowels better. And if they haven't been maximized, they really should before going on to the next step, which is an osmotic laxative, stimulant laxative, or other medications like prosecretory or prokinetic agents. Okay, so and then on the far right, we look for secondary causes for constipation. And as we listed some of those in the previous slide, when those are present, we'll treat those first. For example, removing the offending medication when that's present for that. So it is important to look at the subtypes of constipation, as we just discussed. So when a rectal evacuation disorder is present, and that we would do either based on our digital exam, or when available, we may do some additional testing. And this would be testing of the anal rectal structure and function. Most common test would be like an anal rectal motility study, which measures the pressures on the anal sphincter and the ability to evacuate a balloon, or doing a defecography, which is an X-ray of someone having with a contrast in the rectum to see how well the rectum moves when trying to push that contrast out. And when those are abnormal, then someone may be diagnosed with a rectal evacuation or a defecatory disorder, and those patients are best treated with biofeedback therapy. And this oftentimes is done in conjunction with medications, but really it is the biofeedback therapy that can really change their long-term course. So if the anal rectal structure and function tests are normal, then we would consider doing a colon transit test, and that's to see if they have normal transit, versus abnormal or slow transit constipation. And really, as you can see, that the treatments are fairly similar. For both, we would consider prosecretory agents. We also consider prokinetic agents, prescription medications, which are available through your physician. We may also be giving some stimulant, adding stimulant laxatives or even enemas. And the patients with very severe slow transit constipation, this is very rare in our practice, but it happens several times per year. They may end up having to have surgery to remove their colon because it's so refractory. The other group with normal transit, we consider it usually treating with medications. We almost never take out their colon in those cases. So in summary, constipation is a common problem that impacts patients' lives and has a significant economic impact on our health system. Functional constipation is the most common cause for constipation, but we must consider secondary causes as well. Subtypes of functional constipation include slow transit, normal transit, and defecatory disorder. And the defecatory disorder is very important to diagnose because the treatment is biofeedback therapy. Treatments in general for constipation include lifestyle modifications, diet, particularly fiber, exercise, and fluids, as we mentioned. Laxatives can be used, including osmotic and stimulant laxatives. Prescription medications such as prosecretory and prokinetic agents are also available through your physician. And as I already mentioned, biofeedback can be helpful for people with a defecatory disorder, so we really do want to identify them when present. Thank you very much for your attention.